Anyway, people are going to they're going to the hospital, they're going to urgent care. A lot of people are getting turned away if they don't have fever. This is really, guys, all about getting tested. And if we can't test the population, there's really no way that we're going to be able to get back to this. So what I really want to hear is what are their thresholds for this? And do we have enough tests? Are people, can doctors order the tests? Here we go. We're waiting on Dr. Jake. Okay.
Okay.
Okay, I got my earpods in now.
Oh, that sounds good.
That make you good. I think we got it this time.
Yeah.
Our audience keeps coming back though. I love it, Jake. It's good.
That's determination. I mean, I would have given up.
Well, they want to hear from you. And I keep saying, like, what is, A, is there access for doctors like yourself to get tests, as many as you need? And B, what is your criteria? Because I think there's all the different places have different criteria. I've heard some places being, if you don't have a fever, we won't test you.
Right. Yeah. So, I mean, we have access to testing that's pretty unlimited at this point. They're giving us about 50 swabs per office, but we don't run that many each day. So we've accumulated some excess. And that really allows us to have pretty free range with who we test and kind of just doing our thing. So we're testing doctors, we're testing nurses that are unable to get access, police, fire department personnel. And our criteria is essentially whoever needs it.
Right. What about that patient who is positive and wants to know if they're now negative so they could leave quarantine and be around their family and whatever?
Yeah, that's a tough one. I mean, we're trying to stick to people that are essential, like a doctor that needs to go back to work.
Yeah.
Just because we do have a good supply, but it's not unlimited.
Right.
And, we just also want to set the standard that we want to use it wisely at this point.
Yeah.
As we get more capacity, as we have unlimited testing and mass testing, then I think that would be a more commonplace practice. And then certainly antibody testing will allow us to determine if people have immunity. So that'll be a big step.
I ordered those antibody tests as soon as they were available. It was about 2 weeks ago. They were supposed to go through customs this Saturday. They were supposed to arrive today. And I heard from my rep at Henry Schein that they're still in customs lockup. It's like, nothing's easy, right?
No, I mean, we're practicing medicine like it's in the black market, getting PPE from sources that, are somewhat shady, just sort of scrambling to do whatever we can. When we started testing people, I wasn't working with BioReference. I think it was a Saturday, and I just dropped everything, got all of the processes in place for our office to get the testing done. So, it was like guerrilla medicine in a way.
Yeah, absolutely. Do you have recommendations for people who maybe have it and want to donate their blood?
I mean, I know at Mount Sinai, they're interviewing people to donate plasma. Also,
I think 21 days. I think they want 21 days, but they want a positive and a negative test, which for me is difficult because I don't have that. I wasn't.
Yeah, you never had the positive test. Yeah, so I'm not sure exactly the strict protocol that they're following, just because I haven't been involved with that. I mean, I would love to donate my plasma too. I had a positive and now 2 negative tests. And, really what I was trying to understand by testing myself, one, is what does that look like for the timeline to get a negative test? And then, 2, is it really an accurate negative? Because there were some reports of people that had a positive later. So I was using myself a bit as an experiment. But also the other interesting part is I tested other people that were sick, not as bad of symptoms, who didn't take hydroxychloroquine, tests still showed positive at 3 weeks. So
did you take it like me? We both took it, right?
Mm-hmm.
Yeah. I didn't take it till late, till like day 12. Everyone's very much caught up in the tests. They're caught up with the antibody immunity. They're caught up with the reinfection, all these things. What they don't realize, and I know you would agree as a physician, a test is just a piece of the puzzle. It's a piece of the clinical picture. You can't rely. I mean, I'm very happy I tested negative, but I'm not walking around making out with people on the street. You know what I'm saying? I'm still acting
No, but
defensively.
The danger is when we test people and they get a negative result, then they assume, okay, I'm good. I don't have to worry. But in fact, that's something you should probably be more concerned, because now you're vulnerable. You know, if you haven't had an exposure, you're more likely to get sick later, and who knows what that's going to look like for your particular illness.
Absolutely. And even when this antibody test comes out, it's going to probably cross-react with maybe other coronavirus type things. There's going to be some,
maybe,
that's what they say. I think the molecular testing is a specific but not sensitive, whereas with the antibody test, it's the other way around. It's sensitive but not specific.
Right.
If you have an antibody, you definitely have
it.
But we don't know exactly what antibody you have.
Everybody's been exposed to coronaviruses. That's the common cold.
Exactly.
And so unless it's specific to COVID-19, that's useless information.
So, it's another piece of the puzzle. But what we really, because the next question is, so many people are getting it now. When are we going back to life? No one's going back to life until we have a steady supply of this testing. And that not only do we see a downward curve and we watch our hospitals and urgent care centers being able to handle the volume, but we really need the access to these tests. Don't you agree?
Yeah, and treatment, a treatment option and a possible vaccine. Like, that's going to really change the trajectory. I mean, if tomorrow they said hydroxychloroquine is universally effective to treating this, then we have a significant change once we get some of the critical masses of people that are very sick under control.
Even 70% effective. We all know you could take 10 people with a headache. Some people do better with Advil. Some people do better with Tylenol. What they need is several different protocols, because there's nothing that's going to be 100%. And I think a vaccine, I mean, if we wait for a vaccine, we're going to be indoors a long time. It's really about treatment protocols. The reason why I didn't take hydroxychloroquine at like day 5 and I waited to day 12 is because I honestly believed data would come out in that week that my symptoms started, right? If they start treating everybody, maybe we'll get some data, but I don't know. I still haven't heard any data. Have you?
But I think it's important for people to know that, both you and I had really bad illness. Pneumonia. I had pneumonia. We were not like mild cases that we were just using this medication, because people are going to start trying to obtain this unnecessarily. And, when you talk about how sick you were giving yourself oxygen. You were using supplemental oxygen.
I know. I'm telling you, people
crazy.
are trying.
I was thinking about it today. I mean, I'm an ER doctor. We're warriors. You know what I mean? We'll MacGyver anything. But I wasn't at home giving myself oxygen. And here you are, a derm guy, and you're, setting up basically home therapy.
Oh, I know.
So, I think that's really important, because if people are listening and saying, hey, I got to get hydroxychloroquine, I'm worried about getting sick, that's not the solution at this point. No. Luckily, it is readily available. And luckily, there isn't a limited supply, but right now we want to make sure that it's given to the people who are, critically ill.
Yeah, and there are signs outside of every pharmacy that I've been exposed to saying that they've been mandated, which is true, that they cannot dispense the medicine unless it's for an FDA-approved purpose that has been prior diagnosed. So they're not giving it out easily.
I've seen also that you have to have a positive test. So the prescription would have to come in with a positive test.
Oh, that's good. I mean, I know there are people, unnamed doctors, they're taking like 1 pill a week because there's some study about prophylaxis or things like that.
Well, I mean, I don't know the specific information there, but it might make sense, especially, let's say if you're an ER doctor or you're a critical care doctor and you're putting patients on vents and high degree of exposure, maybe that is a sensible use in terms of that population to prophylax.
Yeah. I find it very interesting. I'm curious of your opinion. It's just anecdotal, but I find it's people like us who are healthy, strong immune systems. There's something about that cytokine storm, that pneumonia that develops. It's because we're healthy. My 78-year-old healthy father with no predetermined thing, I really believe he had it a month ago, but he had it very mildly because he doesn't have the strength of immune system we do. It's probably another reason why kids don't get it. It's that like middle population.
I'm not an immunologist.
I know.
Yeah.
It's just weird.
It is a weird, and we're going to learn so much about what each part of these process means. Like I have a theory that some people have more of a genetic disposition. My dad had really bad symptoms, got in the ICU, was intubated. I had pneumonia, so like that to me shows that there's a genetic component of who's going to have more severe
Did
illness.
Brian have pneumonia as well?
No, I mean,
No.
he had a fever for a couple of days and then was done.
Were you sick at the same time, or was it staggered? Oh, I lost you there. Yeah. Were you in sync with your illness or separated?
About the same time. I was a day later with the fever, but then I had 14 days of illness and he had 3 days. So a real big discrepancy in terms of our experiences.
Wow. Now, you and I are both affiliated with Mount Sinai. I speak to some of the people there every day. I assume you do. Any input for like the audience about in terms of are they handling the load there? Is it like total mayhem? I get the impression they still have supplies. They still have ventilators. As grueling as it is, they're managing.
Yeah, they're definitely managing. I mean, I was in the ER 2 weeks ago when I was sick. I've been in touch with some of the people that I know there. It's definitely not a fun environment, though. It's wartime medicine. Very uncontrolled, very chaotic, very high level of stress. I was in the ER. I've been an ER doctor for the majority of my career, and to be uncomfortable in that environment was really difficult. And
that's why I didn't go
out of my comfort zone.
Yeah, that's why I didn't go. I was definitely afraid.
Getting sicker. The idea of getting sicker and having to go back there as a patient was horrifying, and being admitted and being isolated like that in this environment was horrifying.
And no one can get in touch with you other than your phone. There's no visitors. There's no dropping off. I mean, I have people texting me like, where do I get oxygen tanks? Like, I certainly don't want people going that far. If you're having problems breathing, a lot of people are getting a pulse ox, which I think is the greatest tool, correct?
Yeah. No, knowing that your oxygen is okay is a critical factor of, assessing how sick you are. Yeah. But I don't think people can find them. I mean, I know patients consistently report that they can't even get thermometers.
Oh, really?
Yeah, really? I mean, it's just crazy to try to manage at home and not being able to check your temperature.
It's funny. I had a lot of patients and friends and stuff who had hacking coughs. They felt like they had shortness of breath, but it was clearly in their upper respiratory because their pulse ox was like 97, 98. And then there were other people who had mild shortness of breath, mild stuff, and they were in the low 90s like me. It's really wild.
Yeah, because it's like a lower, deeper infection. So you're not getting the cough reflex because it's not triggering, the areas where you swallow in the trachea and epiglottis, but it's actually getting deeper within the pulmonary tree down in the lungs, and you don't get as much of a cough from it. But yeah, you're right. That's really the scary part of it.
So the pulse ox, people are saying, they are still available on Amazon. It does take a couple of weeks to get, it's a stressful situation, but I keep telling everybody that's the main thing. It's a pretty easy diagnostic tool. 95 to 100 normal, 90 to 95 cautious, under 90, you need to go to the hospital, correct?
Yeah, no, that's definitely an indicator. And I've spent quite a bit of time talking to patients who have mild illness about what to watch for. It's the real difficulty breathing, the pain in the chest, feeling like something's not right, looking for signs of hypoxia, like blue lips and,
oh God, I was checking my lips. I was checking my lips constantly.
Yeah. No, I mean, that was a conversation that I was annoying Brian with. How's my color? How's my color?
Yeah. How about nebulizers? There has been a little controversy. For me, I think they really kept me out of the hospital. Are you prescribing them at all?
We're using inhalers for some patients, particularly had respiratory complications, like if they had bronchitis and they were wheezing, sort of a tendency, or if they're asthmatic, of course. So we're using those quite a bit. We're not using them in the office as much as we don't want to aerosolize the virus.
No, I think that's the main thing.
Normally we treat.
The nebulizers have to be used in isolation. Yeah. I mean,
it's potentially a vector to get the virus spread.
Yeah, they really helped me out though. So I think that's a great. If people are going to stock up with any prescription, that's maybe not such a bad one to have, you know?
Yeah, especially if you're prone to having bronchospasm or wheezing when you get respiratory infections.
Yeah.
That's really a good indicator to use it.
Have you seen more men than women, and have you seen young adults, like teenagers?
I don't think there's a disparity between sexes, equal men and women.
Yeah.
Not a lot of young adults. Maybe one or two persons that are under 18, but for the most part, not so much. And I actually kind of did an experiment with a family, two adults, both tested positive. A baby that was 1 year old that had a little bit of a runny nose, no fever, tested the baby who clearly had been exposed and tested negative.
Yeah.
So that was a bit of, the experimental information, but it's interesting because, you just wonder why the baby didn't have any signs of having, been sick.
Well, it's, the whole 1918 pandemic type of thing, it was unique in a similar way that it targeted mostly people like us, like working middle-aged people. You know what I mean? Medicine was completely different back then, but again, only time is going to tell what's going to come of all this, and whether or not we're going to have it next year, and all these things. People are on to the next stage already in terms of like what's going to happen.
No, of course. I mean, we're trying to get past this, and we need to be prepared beyond immediate situation. So that's inevitable. But we're not done. I mean, I think we're going to be at least a full month of staying at home in the United States.
I think a month would be great. If we could all get back to life in mid-May, I don't know. I think that would be such a blessing in disguise. Hopefully a lot of that will be because of the flattening of the curve and the access to tests and things like nature. Is there anything, and then we could wrap it up, is there anything that you see out there professionally that you wish like we need the improvement on to really make the change? Is there any frustration that you're having?
So much. People just cannot wrap their heads around this. I'm testing people all day long, and I say, I think that your test is going to be positive. You try to inform. It's important to maintain isolation, and then we go over the results. I'm calling a lot of people myself, and the response time after time is really, even though
really
you have a very, very clear conversation. I think you're going to have a positive test. This reason, this reason, this reason. People still are surprised, and that's really the difficulty here, because then if people aren't getting tested, right, we're saying stay home, stay isolated, and they don't really connect the dots that they potentially have been sick or have illness that they could be transmitting, then they're not going to be as stringent or, rigorous about. So many times a day. I have that conversation so many times a day. How important it is to communicate.
Crazy.
And teach.
Yeah. Well, I got to tell you, man, I think this is like an amazing conversation. I say it with earnest honesty. If you have any issues with your staffing or anything else, I'm there to come help out at your clinic, the Cure Urgent Care Clinic. I'm not, seriously, I'm I'm waiting a couple of more days so I could hit the front line. Getting a negative test was amazing. I want to do anything I can. So there's nothing that would make me happier.
I know my staff could definitely use some skincare and some facial treatments after wearing masks for weeks on end.
Absolutely. I will come in and give everyone chemical peels, whatever they need. But in all honesty, I'm there for you. I appreciate what you're doing, boss. You're taking the load off a lot of people. And if you need my help, that's great. You can come work for me too.
Okay, I would love to any day.
All right, buddy. All right, guys. I'll see you later. Thanks, everybody.
Bye.
Bye. All right, guys. That was amazing. Dr. Jake, Cure, Urgent Care. If there are any little final last questions here, that was amazing. It's nice to speak to someone on the front lines. And it's nice to speak to a peer who went through it. Sam, you need a chemical peel too. I know. That's the amazing thing. I was saying earlier, after 9/11, there was this feeling that life would never go back to normal again. And with this, I really have no doubt that life will go back to normal. It's going to be different. It's not going to be the normal we know, but it's going to be a place that is as good, because we are driven to live our lives, and we're going to hit that again. So thank you, Dr. Jake Deutsch. Thank you, everyone, for tuning in. I'm going to stay on board here, but most importantly, I think it's time to have a cheeseburger. All right. I'll see you all later. Bye-bye.